Well, greetings and welcome to the Docs In episode at Cleveland Clinic, Abu Dhabi. My name is Zaher Koutoubi. I'm a consultant gastroenterologist within the Digestive Disease Institute at Cleveland Clinic, Abu Dhabi. The topic today comes with the occasion of the IBD Day, which will be on the 19th of May, 2024. And the discussion will be with Dr. Sara El Ouali, who's a consultant gastroenterologist also at the Digestive Disease Institute, with a specialist also in IBD. Sarah, great to have you with us. So, inflammatory bowel disease, a great topic and very important disease. So, we know that there's something called Crohn's disease, ulcerative colitis. Tell us more. What is inflammatory bowel disease?
Thank you, Dr. Zaher. It's such a pleasure to be here with you today, especially on this important day that we need to raise awareness on IBD. So inflammatory bowel disease, we also call this IBD. Essentially what it is, it's a disease that causes inflammation of the bowels. And there are two types, as you mentioned. There is something called Crohn's disease and something called ulcerative colitis. And these are two types of essentially bowel diseases where there is inflammation of the bowels. They're a little different in the sense that Crohn's disease can involve any part of the bowel or any part of the gastrointestinal tract. In fact, could be in the mouth, in the stomach, whereas ulcerative colitis is actually only in the colon. And it's important to differentiate from other diseases, because they lead to specific symptoms. And actually, if you leave them untreated, they can lead to complications. So it's really important to make a diagnosis and have
great.
those patients referred.
So basically, we're talking about an inflammatory disease. It is not something different than what we call irritable bowel disease. Some people come with abdominal pain, and they have mistaken it between irritable bowel and inflammatory bowel. Tell me more. What is inflammatory and what is not inflammatory?
It's a great question, and this is a question we get very often. So irritable bowel syndrome is very different, actually. So irritable bowel syndrome refers to a syndrome which is essentially patients can come to us with symptoms of abdominal pain, diarrhea, bloating, constipation, but they have completely normal bowels and completely normal tests when we do all the tests. And in fact, it's important to differentiate between inflammatory bowel disease, which causes inflammation and real damage to the bowels, and why do we really need to make a difference? Because the treatment is completely different.
So when patient comes to the clinic, what are the symptoms? What do they feel? Do they have pain? How do they feel from the inflammatory point, and what do they feel from the irritable bowel point?
Right. So as we discussed, patients with irritable bowel syndrome can have a kind of a variety of symptoms. It could be abdominal pain, bloating, some diarrhea, some constipation. Sometimes they can go between diarrhea and constipation. But they're not expected in irritable bowel syndrome to really have, for example, things like weight loss or blood in the stool, whereas in inflammatory bowel disease, whether it's Crohn's disease or ulcerative colitis, there are going to be some symptoms that are a little bit more serious, let's say. And those can be, again, diarrhea, going a lot to the bathroom, having blood in the stool, abdominal pain, losing weight, even though you're not trying to lose weight, things like fever. And, inflammatory bowel disease can also affect other organs in the body. So those patients actually may even have things like joint pains or back pain, ulcers in their mouth. So really important to try to figure out the difference, because sometimes patients will actually have similar symptoms, whether they have irritable bowel syndrome or inflammatory bowel disease. But again, because the treatment's so different, it's so important to make a difference.
So there is something what we call the red flags. So what are the red flags which we should watch for in inflammation?
This is such a great question. I think it's important for patients and for doctors as well to know this. When is it that I have to consider my symptoms being red flags or being more serious? So if you have, for example, blood in the stool, that's when you really should come and see a doctor. If you feel like you're losing weight and without really it being unintentional, then you should really come and see a doctor. That's another red flag. Things, for example, like having a bowel movement in the middle of the night, which is, normally not really seen, but if you have to run to the bathroom even in the middle of the night, that's another bad symptom that you need to really follow up with your doctor. And of course, things like weight loss, fever, and the flu of, a bunch of other symptoms as well.
So bloody diarrhea, weight loss, anemia, these are great points they should watch for. Wonderful, Sarah. So, when patient comes to the clinic, we take a history, we do a physical exam, we order some investigations, correct? So, what
That's right.
investigations we should order for patients? Tell me.
That's right. So it's a good question because you know what? The biggest and the most important thing is that visit, their first visit with you in the clinic, because that's when you ask the right questions. And a lot of the times you can tell from that first visit what's happening, or you can actually get a little bit of a suspicion. And why is that important? You ask about symptoms, you ask about complication symptoms, you ask about extra, other organs that may be affected, family history. And so it's kind of like an investigation that's going on through our minds, where we kind of put the pieces back together. Physical exam is very important as well. And then once we have that, usually it depends on how the patients present, but usually we like to order blood tests. Sometimes the doctor may order stool tests to check for infection or inflammation.
Yeah.
And then the best test really to check for inflammatory bowel disease still remains a colonoscopy. So, that's the little endoscopy with the camera at the end of it that we essentially put in the bowels to really look at the inflammation directly. And we can even take some little pieces of biopsies to really diagnose the problem and confirm it.
Great. So, stool studies, some blood work, endoscopies, how about some x-rays?
Absolutely. So then it all depends on the situation. But a lot of the times, to get the full picture, you need to see the small bowel as well. So the colonoscopy, a lot of the times, is going to just see the colon and the last really bit of the small bowel. Whereas, for example, an endoscopy that we often get in these situations as well would only look at the stomach and the upper part of the small bowel. But to look at the rest of the small bowel, you would really need a CT scan or an MRI specifically for that purpose. And another thing that we actually sometimes do is a video capsule endoscopy, which is a capsule that patients can swallow. In specific cases, we don't do this routinely in everyone, but it takes pictures and almost like a video of the whole small bowel, and it can really show us if there is inflammation or disease in those small bowel.
Yeah. Now, you mentioned something very interesting. When the patient comes, we have to take a history, physical exam, and you mentioned the extraintestinal manifestations. What do you mean?
So what I mean by that is, Dr. Zaher, what ends up happening is that these patients end up having inflammation that kind of goes beyond just the bowels or just the gastrointestinal tract. So they may have things like ulcers in their mouth or joint pains or low back pain, skin changes as well. So we have to ask them for skin changes, any really changes that have happened to them recently. And based on that, that gives us clues to the diagnosis, but also helps us figure out what's the best way to treat them, because different treatments will be essentially targeting different things. If someone has IBD with specific organs that are affected, they may need a specific treatment for that.
So this is a great, actually, discussion, because when the patient comes, let's say I got a 15 years old or 20 years old with abdominal pain, bloody diarrhea, weight loss, anemia, has back pain, some eye issues. So I would think more about inflammatory bowel disease rather than thinking about irritable bowel syndrome. So irritable bowel syndrome, what other symptoms patients they can have? Pain, constipation or diarrhea, sometimes bloating, and it is also related to diet, and that brings big questions about diet. So in inflammatory bowel disease, what do you think about diet? What do we advise our patients usually?
This is the $1,000,000 question. There's a lot of studies out there trying to study the effect of diet on inflammatory bowel disease. We actually don't know the cause of inflammatory bowel disease, but there are some studies that are telling us or showing us signs that maybe diet may even be one of the causes of Crohn's disease or ulcerative colitis. It's very hard to actually prove. But for example, things like having a diet that's full of ultra-processed foods, so foods that are transformed, not natural ingredients, that actually has been shown to maybe be associated with the risk of Crohn's disease. So of course, what we end up telling our patients is to avoid this type of aggressive diet, essentially. So we avoid junk food, we avoid fast foods, anything that's very processed. We avoid red meat, too much red meat, so just moderation is best. And in general, a Mediterranean diet, full of vegetables and fruit, olive oil. That's probably what's best for our patients. But again, there's a lot of studies still going on, and the right diet is very difficult to really discuss at this point.
Now, you mentioned family history. This is very important because we do see patients age 14, 15, they have even sisters or cousins. Does genetic play a role in this?
Absolutely. So that's a great question. And so you remember we were saying that we don't know the cause of inflammatory bowel disease, but we think that there may be a genetic predisposition. And why is that? We have found genes that have basically accumulated, or mutations that accumulate in patients with Crohn's disease or ulcerative colitis. And we also know that in some families, if one person has, for example, Crohn's disease or ulcerative colitis, that increases the risk of someone else in the family to have that disease. We see this probably in about 10-15% of our patients, but that's not the full story. There definitely has to be another cause and another factor that's really involved in the cause of inflammatory bowel disease.
It's a multifactorial, not only one cause. Lots of patients ask me about smoking. Does smoking play a role in inflammatory bowel disease?
It really does. It really does, especially in Crohn's disease, where we really think that, first of all, it may actually be a risk factor for catching that disease. Again, it's tough to prove, but it's what our studies have shown us. But the other thing with smoking is that what we know for sure is that patients that smoke and have Crohn's disease really have worse outcomes. And what I mean by worse outcomes is that they do not as well as patients that don't smoke. So they can have more complications, a more difficult Crohn's disease, essentially, harder to treat. So really important to really stop smoking if that's the case.
Yeah. You know, since we started Cleveland Clinic in 2014-15, now we have in our center more than 1,200 patients. Why we have so many cases? Why the numbers are increasing in UAE? Any idea?
It's a great point, and I think what we're trying to figure out in general is why is it increasing in the world? And we don't know. We don't know. There are trends over the last few years. You know, it's really, quote unquote, exploding in the West. And it's starting to really increase in countries, in this area of the world. And there has to be something environmental. Again, is this diet? Is this westernization of diet? Pollutants? We're really not sure. And
All of the above?
All of the above. And we still have a lot of studies going on. And hopefully in the future, we may be able to pinpoint at it, what the right, what the exact cause is. But really tough to tell.
So patient comes, we're going to do investigations, blood work, stool studies, some CT or MRI, and the important one is the colonoscopies or the endoscopies. How do you put it to the patient? And lots of patients are afraid to go for colonoscopies. How do we explain to them the procedure?
It's a very good question. And, we get this question every day with our patients. It's not an easy test to go through when you think about it, right? But the main thing is to think that if you do that and we find the cause, you would feel much better afterwards. And in fact, what we do is we put patients to sleep during the procedure, so they actually feel nothing, absolutely nothing at all. The most annoying, I would say, part is the day before, where patients have to take a laxative to really empty all their bowels so that they're able to undergo the colonoscopy the next day. But after that, once they come to us, we put them to sleep, they wake up refreshed and feel great, and then we come and tell them what we found.
Like today is my endoscopy day and your endoscopy day. So patients are happy when they leave because we always tell them, what are your fears? If they are afraid that they're going to have pain, they will have no pain. And after they leave the endoscopy, they are very happy. If they are afraid that they will be awake, actually they will be sleeping. They will not remember absolutely anything. And this is a very important point when we explain to the patients. So,
it's a good point. And the other question I get a lot is, do I have to sleep in the hospital? And no, this is just a day procedure. They're here just literally for a couple of hours, and the procedure lasts not even 30 minutes. And so it's a really, really short procedure. It's a very safe procedure overall.
So let's talk about treatment. Now, this is very vague discussions because treatment for inflammatory bowel disease is very interesting. Now, people talk about classical medication like Asacol, Pentasa, other mesalamine classes, and people talk about biologics. I used biologics in 1998 when infliximab or Remicade got, approved. Now, till 2024, we have lots of medications. So how do you put it to the patient? What do you tell them? How are you going to treat them?
So it's a good question. What happens is that over the years, we've had a lot more choices over
Yeah.
time. I'm not going to say a lot because it's still not enough, but we've had a big development of new molecules, new biologics. And so let me explain a little bit what this is. Really, the treatment depends on the type of inflammatory bowel disease, first of all, whether this is ulcerative colitis or Crohn's disease. Some treatments can be given for both, but some treatments, like for example, mesalamine, can only be given for ulcerative colitis, really. And what happens is that it all depends on where the inflammation is. So let's say for someone with ulcerative colitis, depending on where their inflammation is, they're going to have different treatments. It may be just the last 5-10 centimeters of their bowel that may be affected, and it may be the whole bowel. And, that will really dictate what type of treatment they need. And in Crohn's disease, in general, we tend to start on immunosuppressives from the get-go. And what do I mean by immunosuppressive? So the reason we use medications that can impact on the immune system is because we think that this whole problem is because of the immune system. So the immune system essentially attacks the bowels. It's an autoimmune disease. And so when the immune system attacks the bowel, it leads to inflammation. And so sometimes you have no choice but to decrease the immune system or to target those little soldiers, as I put it for patients, target those specific soldiers that may be involved in the attack in the bowels. So we're not completely suppressing the immune system or decreasing the whole thing. We're just targeting specific soldiers. And so this can come in the form of things we call biologics or advanced therapies, and they can be given by veins, they can be given subcutaneously, which means on the skin, injections at home, it can be infusions in the hospital. There's really, now we even have pills actually that are advanced therapies for ulcerative colitis and Crohn's disease. So it really all depends. Remember we were talking about if the disease involves other parts as well of the body. So it's going to depend on a lot of things, and that's why your doctor's mind goes through a lot of different, in a lot of different ways when we need to really decide on a treatment.
Yeah. The way how I put it to my patients, I tell them the immune system is supposed to protect you. Now, sometimes get confused, so it's tough to attack you. So this is very interesting. So the patient don't know what is the immune system. Basically, it is your defense mechanism. So sometimes they get confused, and that lead to many issues. Now, we know that, these treatments are not so simple. That's why we're very proud actually in Cleveland Clinic to have an MDT meetings. So these, the complicated patients are discussed within a meetings. Tell us more. This is your baby. Tell us about the MDT meetings.
So what we mean by MDT is really multidisciplinary team meetings. And what we do here at the Cleveland Clinic Abu Dhabi, and what we really should be doing in all good centers, is to discuss patient cases together. And what I mean by together is together with other gastroenterologists that specialize in inflammatory bowel disease, like you, like Dr. Alam. We get together, as well as getting together with surgeons that specialize in inflammatory bowel disease, pathologists, the ones that actually read the biopsies, radiologists, the one that read the x-rays and the CT scans and the MRIs. Sometimes we need to meet with the rheumatologists as well, the ones that specialize in joints, because really this disease can affect multiple facets of the patient's life. And sometimes we have to make a decision altogether, what is the right approach? What is the right treatment for this specific patient? We also are very lucky to have nutritionists as well on board. And it helps a lot because, we were talking about the diet, but nutrition is extremely important in those patients. A lot of them lose weight and need to really rebuild. And it's important to have nutrition on board.
So these diseases are so complex that they don't need a physician. They need a full team who can take care of. And that will come also when we see the patient in the clinic. We do refer them to surgery, we refer them to nutrition, which they can help a lot in the management of these patients. Sarah, tell me, what about surgery? Is it an option?
Absolutely. So surgery is actually an option for both Crohn's disease and ulcerative colitis. And again, there are different types of surgeries for different types of patients and different types of diseases, or I would say patterns of diseases. Sometimes some patients with Crohn's disease can have anal issues and they may need anal surgeries. This is why we work so closely with our colorectal surgery colleagues, sometimes if medications don't work, or if sometimes, if there's a complication, like sometimes blockage in the bowel, a medication is not going to do anything once there's a blockage. And so surgery can really help. And in fact, studies are showing us that surgery may not even, it's probably not a good idea to leave it to the very end. Sometimes we really work with our surgeons to really find the right treatment plan for a patient. So maybe for a patient, the right treatment is surgery from the get-go. And because you don't want to be wasting their time and making them worse over time when really what they need is surgery. So we work very closely with our surgeons. They see our patients the same day and vice versa. And essentially, we try to have these discussions with them. What is the best way to really manage a specific patient?
Yeah, and we are very lucky to have actually a multidisciplinary team with surgeon, dietitian, nutritionist, the radiologist, the pathologist, which actually put the best diagnosis and management for these patients. So these meetings actually is to raise awareness that inflammatory bowel disease is an important topic. It is nothing to, like irritable bowel or like, simple things. People need to know and be aware about these diseases, and they need to have hope that these diseases have, there is medication for it. And that's why we have a full center in Cleveland Clinic, Abu Dhabi, and we're very happy that we all coordinate together to get the best of care to our patients. So thank you very much for joining us to this episode, and where we discussed with Dr. Sara inflammatory bowel disease. Until next time, thank you and goodbye.